All right, let's get into it. We're about to tackle one of the most amazing things the human body can do, pregnancy. This is going to be your ultimate study guide. We'll break down everything you need to know, not just for your exams, but for when you're actually out there on the floor.
So, how does the body pull off this incredibly complex transformation? And more importantly, how can you get a real handle on it for your exams and for your practice? I mean, it's a total biological marvel, right? Understanding these changes is, well, it's non-negotiable for nurses. So, our goal today? To turn all this complex physiology into stuff you can actually use. Let's kick things off with the very first clues. Okay, so where do we even start? How do we begin to think, maybe there's a pregnancy here? Well, the signs are actually broken down into 3 different categories. And trust me, you have to know the difference between these. It's totally fundamental. This table lays it out nice and clear. Think of it like this. Presumptive is what the patient presumes. It's subjective stuff they feel and tell you about, like, I'm so tired or I feel nauseous. Then you have probable. This is what an examiner finds that makes a pregnancy, well, probable. It's objective stuff like a positive pregnancy test. But here's the kicker, and this is so important. Both of those categories could be caused by something else. The only ones that are 100% no doubt about it proof, those are the positive signs. They mean there is definitely a baby. So let's dig into one of those probable signs. A classic one is Chadwick's sign. You see this deepened kind of violet bluish color of the cervix and vaginal mucosa. And why does that happen? It's all because of a huge increase in blood flow to the area. It's a really key thing an examiner would be looking for.
Okay, another big one in the probable column is Hagar's sign. This is something you'd find during a physical assessment. The lower part of the uterus just gets incredibly soft and compressible. It's actually one of the earliest, most significant changes to the uterus that can be picked up.
And to finish up our big 3 probable signs, we've got good old sign. This one is all about the cervix. See, the tip of the cervix is normally pretty firm, but in early pregnancy, it softens up a lot. And that's all thanks to those hormonal changes and more blood flow. All right, so we've got our signs. We're thinking it's pretty probable, so what's next? How do we get that solid confirmation and actually start putting a timeline together for this pregnancy?
Well, the answer is all about a hormone called human chorionic gonadotropin. You know it as hCG. It's the magic ingredient that pregnancy tests are looking for. And check out its pattern. It's super interesting. You can find it in the blood just 7 or 8 days after implantation. Then it shoots way up, peaking around day 60 to 70. After that, it drops back down and just kind of hangs out at a lower level for the rest of the pregnancy. Following this pattern is so important for checking if the pregnancy is viable. Okay, pregnancy confirmed. Now what? We need a due date. And the go-to method, the one every single nurse has to know, is Nagel's rule. It's a super simple 3-step formula, and you're going to use it all the time. Just take the first day of the last menstrual period, go back 3 months, and then add 7 days and a year. Easy. You got to lock that one in. Let's clear something up that trips a lot of people up. Gravity versus parity. Gravity is the easy one. Just think G for got pregnant. It's the total number of times a person has been pregnant, period. Doesn't matter what happened. Parity is a little different. It's the number of pregnancies that made it to 20 weeks or more, basically to the point of viability. And if we want to get even more specific, we use the GTPAL acronym. This thing is awesome. It gives you the entire obstetric story in a nutshell. G is gravidity, like we just talked about. T is for term births, babies born at 37 weeks or later. P is for preterm births, A is for abortions or miscarriages, and L is for living children. It really is the whole picture right there. Okay, so pregnancy confirmed, due date calculated. Now it's time for the main event. We're going to do a system-by-system deep dive into the incredible total physiological overhaul that happens during pregnancy. First up, the cardiovascular system. It basically goes into hyperdrive. Cardiac output and blood volume, they both shoot up. We're talking 30 to 50%. That's huge. It has to do that to meet all the new demands. The heart rate ticks up. The heart itself actually gets a little bigger for a while. You might even hear an S3 heart sound after 20 weeks, which is pretty wild. Hold on, let's just stop and think about that number for a second. A 40 to 50% increase in blood volume. That's insane. The body is literally building an entire extra circulatory highway to support the baby. If there's one number you take away from this section, make it that one. It's a classic exam question. Okay, what about breathing and, well, peeing? The respiratory and renal systems get a makeover too.
The body needs more oxygen, so breathing gets a little faster. But at the same time, the uterus is growing and pushing up on the diaphragm, so lung capacity actually goes down a bit. And the kidneys? They go into overdrive, filtering more blood, which is exactly why urinary frequency is such a classic early sign.
Now, the GI system. Things slow down. Thanks to hormones, food takes longer to move through, which is why nausea and constipation are so common. Meanwhile, the musculoskeletal system is scrambling to keep up. The posture changes to handle the extra weight, and the pelvic joints start to loosen up to get ready for the big day. Those same hormones also do a number on the skin. You might see chloasma. People call it the mask of pregnancy, which is just some extra pigmentation on the face. Then there's the linea nigra, that dark line that can show up running down the belly. And of course, stria gravidarum, better known as stretch marks. Okay, that's a lot of physiology, right? We've got the knowledge down. But how do we actually use it? That's what this next part is all about. Connecting the dots between the science and your clinical judgment with some killer tips for the NCLEX. Here's a little memory trick for you, and I promise it'll stick. For your exams, when you're trying to remember the signs of pregnancy, just think this. The only positive signs are positively the baby. I'm talking about things you can actually hear, feel, or see that can only be the fetus, like a heartbeat, an examiner feeling movement, or seeing it on an ultrasound. That's it. Everything else, it's just presumptive or probable. All right, let's talk blood pressure. This is super important to monitor. Here's what's considered normal. The systolic, or the top number, it shouldn't really change much from pre-pregnancy levels. But the diastolic, the bottom number, that one often takes a little dip around 24 to 32 weeks, and then it comes back up to baseline. Knowing that expected pattern is absolutely key, because that's how you spot when something is wrong. And that brings us to something really critical, supine hypotensive syndrome. Here's what happens. When a pregnant patient lies flat on their back, the weight of that heavy uterus can press right down on the vena cava. That's the huge vein that brings blood back to the heart. It basically pinches the hose shut. This cuts off blood flow, which makes the mom's blood pressure drop, and can even reduce oxygen to the baby. It's the reason a patient might suddenly say, "Whoa, I feel dizzy," when they're lying down. I guarantee you will see this on an exam. It's a classic clinical judgment question. Your patient looks pale, feels dizzy, gets a little clammy. What do you do first? You have to act fast. The number one priority action is to get them off their back. Reposition them onto their side. The left side is best, and that will take all that weight off the vena cava and get the blood flowing again. All right, let's put you in the room. Picture this. You've got a client, she's 32 weeks pregnant, and she's lying flat on the exam table while you're getting a fundal height measurement. All of a sudden, she tells you she feels really dizzy, kind of lightheaded. You look at her and her skin is pale, a little clammy. Your brain should be screaming, you know exactly what this is. So, what's your move? Based on your assessment, on everything we just talked about, what is your number one can't wait priority action as the nurse? This is the moment where all that textbook knowledge turns into real-world action, the action that protects your patient and their baby. So think about it. What are you going to do?